Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Kevin. How are you doing today?
Doing great, Dennis. How are you?
I'm doing well. Just a couple weeks ago, we did a podcast on nursing care, and we wanted to talk a little bit more into that and specific parts of not just nursing care, but just patient care, I think. And a big one that I see get screwed up a lot is hypothermia management. And what I'll normally see is, we'll just throw the token ready heat blanket and cover them up with a, blanket. And it usually comes on and off multiple times anyway. And, it could be, comfortable outside, and a very healthy patient actually starts to get cold because they're laying on the ground or what have you. So if it does that when it's on a healthy person in a relatively comfortable environment, it's got to be that much worse with a trauma patient and a trauma patient in even a cold environment.
Yeah, so I think we learn a lot about this in anesthesia because it's challenging to even keep patients warm in an operating room. So let's just kind of walk through the different types of heat loss and just how this happens. So one of the things if you just look at your core body temperature is typically warmer than your periphery, like your arms and your legs. So, and this is just normal physiology. We're just going to bring somebody back to do, say, even just an ACL repair, and a young, healthy soldier who maybe injured himself on a jump. So on the induction of general anesthesia, we cause vasodilation. So that vasodilation then allows some of that warmer blood in the core to go to the cooler areas in the periphery. And the patient, during the first hour of general anesthesia, without actively rewarming them, will lose a degree or two of Celsius. So typically what we're doing is we put a bear hugger on them. That's just, sorry if I use the stuff that we use, and that bear hugger will actively rewarm the patient. But it's challenging because the patient's actively being cooled just by the vasodilation, and then the bear hugger is trying to keep them warm. So you typically do see that dip, and then it takes even an hour or two for that bear hugger to really actively rewarm the patient. So this is under normal physiology in an operating room. So the biggest heat loss is through radiation. So that's just your body emits electromagnetic waves, and it's just the ambient temperature is cooler than your body, so it just transfers heat out into the environment. And I was actually preparing for this. I was reading, there's a really good article that I read, and it talked, and I hadn't heard this before, but there was an equation they used where the fourth power of the temperature of the wall that your room you're in is actually the gradient. So so it's this giant gradient that if you don't have your patient covered, that's 40 to 60% of the heat is lost through radiation. And then there comes convection, which is also a challenge in the OR just because of the way that the air circulates. So if you've ever just looked at in an operating room, the OR table typically should be centered above all the vents that are in the ceiling. And those vents recirculate the air above the patient in order to keep the area clean. So through convection is where you're just taking cooler air and just bringing it across the patient and taking that warm air away from them. So just that chronic circulation of air in an operating room actively cools the patient. And then there's conduction. Conduction is just whatever your body's touching. So if you're on an OR table, and that OR table is 50 degrees and your body is 98 degrees, that's just a temperature gradient, and you'll lose heat that way. But typically in the OR, we've got these big thick pads, and that doesn't happen as much. And then there's the evaporation. So that's just say you're doing a laparotomy and you have somebody's bowels exposed, and there's just fluid, through evaporation, there's heat loss. And then there's the respiratory tract. So every time you inhale, you should breathe in roughly 98.6 degrees. That slug of tidal volume that reaches your lungs should be heated by your own body temperature. And then when you exhale, you can see that your evaporation, so you lose heat that way. So those are kind of the ways that we lose heat. So now the question is under normal physiology, like, what are the ways that you can prevent the heat loss that you know you're going to cause by doing general anesthesia? Well, one of the recommendations is to keep the room at least 70 degrees. And I'll tell you, in the OR, just about every OR you look, it's not 70 degrees. It's a lot colder than that. And then every part of the body that we can keep covered, we do. And I think the one thing that people mistakenly don't do is they don't cover the head. And the head is 18% of our body surface area. So you get a lot of heat loss through your head. So I always put just towels or a blanket over the head just to prevent that heat loss that way. And then we could do fluid warming. So let's say we're doing a big case where the whole entire thorax, the chest, the abdomen is going to be open. So typically how I tackle that situation is I'll put a bear hugger on the lower body. So that would be kind of from the pelvis down. And then I'll do fluid warming. And then I do some sort of a towel over the head. And then we have these things called a hot dog warmer, and that's just stuff that we put under the patient that will actively warm them as well. And even then, doing those three things, the patients, I still struggle keeping them warm. So once again, this is in a 70-degree operating room under normal physiology, without somebody who's a trauma patient who's been running around out in, maybe in the cold, and then they come to you.
Right. So just one quick question.
Sorry, go ahead. Yep.
So, I mean, if just conduction, you're talking about the temperature gradient between the patient and the walls, or I imagine the environment.
Yeah. So that radiation. So
radiation,
yeah, just yep. No worries.
So I've been into like a burn, surgery OR, and they keep that sucker nice and warm in there.
Yes.
Would the I don't know, biggest bang for our buck, I guess, if we had to change one environment, either putting a bunch of blankets on a patient or changing the temperature in the environment, would we be better served putting our energy into that, or more targeted onto the patient?
Well, I would say is if you can get the ambient temperature and whatever you're wherever you are, as hot as you can get it, that's typically the best way to do it. So like we were talking before, one of my first jobs, I was at a big trauma center in Minnesota, and obviously it gets pretty cold, and then you have patients for, say, a long extraction out of a vehicle. They come to us and they are cold. And our trauma bays are usually kept fairly warm. And then we have, I always call them the French fry lights. So we would have French fry lights above the patient. And that typically, I think if you look at the loss through radiation, and that's just the temperature gradient between your ambient temperature and the patient, if you can get the temperature above the patient, that's probably going to help you. I would say that's probably the most bang for your buck. but it's hard when you're outside
Right.
to do that. So anything you can do to get a patient in some sort of a shell, let's say even just a tent, something small to keep them warm, that would be a tremendous help. And then the other portion to that is the heat loss through convection. If you're outside, there's always going to be some sort of a wind, right? Like there's always some sort of air that's traveling above the patient. So if you can get them outside of that, that's another way that you can prevent that heat loss.
Yeah. I just got one of those, I don't know if you ever seen them, the Wrigloo. And it's like a inflatable tent. And it's got this enormous freaking air pump with it, a manual air pump with it. So you can blow it up. Like I tried it out. You can blow it up in like 2 minutes. And so it's got these inflatable ribs essentially, and it puffs out, and you can either put the patient in through the front or back, or if you zip out the bottom of it, you can like throw it over top. You know what I mean? It is not small, that's for sure. It comes with its own like backpack, but you know, just mentioning being able to change your environment. Obviously, you're going to have to put them in some kind of structure of some kind, right? But that's just what it came to my mind is like, that's a fairly quick way to get some kind of structure, and then we can start trying to rewarm it.
Yeah, I think speaking to a couple of my buddies that have brought tents when they've done some of their, and I'm not talking like giant like 6 people tents, like maybe like a 2-person tent where you can't yet if you're going to be working on the patient, you're on your knees. And I think what they had said, it was about 30, 40 degrees outside. And just from their own body temperature being in the tent, they were able to get it up to, 55, 60 degrees in there. So, I mean, that's huge. Like if you can get a patient in there and get them in some sort of a structure where your own body heat will eventually warm the area that's going to prevent them from, it's not going to totally prevent them from the radiation heat loss, but at least it decreases the amount that it's going to happen.
Yeah. And definitely when you're working, like you can heat up a spot, that's for sure.
Yeah. So those are so that's kind of how you would try to deal with radiation. The radiation heat loss is just by heating the environment that you're in. And then the convection, just simply, if you can get them inside some sort of a fixed structure and there's no air blowing on them, that's another way to prevent heat loss. And then somehow we've spoke about this before, and when you're on a litter, and a litter versus say like a blow up mattress for camping, like there's nothing underneath that litter, and that allows for that portion of your body to have radiation heat loss. It also allows that portion of your body to have heat loss through convection. And I always tell guys, like some of us have, some of them haven't, but if you've ever slept in a hammock in a colder environment, your back is freezing, right? So like you can never get comfortable just simply because of how cold your back is. Like the anterior portion of your body is nice and warm, but you're just always moving around. So I'd always, if I was in that type of place, I would take my blow-up mattress and I would put it in my hammock, and then I would jump in there, and then it was great, just simply because I didn't have that heat loss through the posterior portion of my skin. And so the early days of my deployments was like 2004-ish. Like whenever we would transport patients, we would always take those the thick green army blanket, the wool blankets, and we would put them on the litter, and we would put them, almost 2-3 thick. So that way we noticed that we would keep the patients warmer when we did that, and the patients would be cold when we didn't do that. So that was just, it was just observational type stuff, but that's something that we figured out quite early on, that like to keep a patient warm in a helicopter, you had to put those blankets under them. And then that provided padding as well to the patients. So that way
Yeah.
they're not sitting on those litters for hours on end and then causing the skin breakdown that we talked about in the nursing talk a couple weeks ago.
Yeah. Speaking about that, I was wondering, like the air mattresses I've noticed in hospitals, I don't know if it's exactly an air mattress, but there's definitely some like very soft cushioning on the beds themselves, and that they can, like, I don't know if it's through pneumatics or pumps or whatever, but change the pressures on either side of the mattress. Just thinking more austere, do you think just using like an inflatable mattress or some kind of very soft foam, because it seems like they're not really when in the hospital, when they have those, they use those pneumatics or pumps to kind of turn the patient versus, propping up towels and things like that underneath them. Do you think you'd be able to extend things out with an air mattress?
So those mattresses are amazing, but so they typically it provides pulmonary toileting for you because it's kind of turning the patient by itself by inflating the left side of the bed and the right side of the bed, etc. And then it also what they're trying to do is decrease the amount of pressure on the skin at any one given point. So those are two different things they're trying to do, but I would say absolutely. I think one of probably the best thing you could do is to get like I talked about, those commercially available blow up mattresses for camping, the smaller ones that have some sort of thermal protection, like the one that I've got. It's got some synthetic protection in there, so that way I can sleep on cold ground and it doesn't allow the cold to get up to me. But it also provides decreasing the amount of probably pressure sores that you would get. You're still going to have to turn the patient. You're still going to have to do those things, or if they can turn themselves, that's even better. But getting them off of the ground, which is going to be cold, and then also providing some padding for them, which is going to decrease the skin breakdown. So absolutely. I think, like, if we're really talking about prolonged field care in an austere environment, depending upon how many patients you think you're going to have, just some sort of padding to get them off of the ground, and then also to protect their skin. Hey, Dennis, give me 1 sec. I got to close my door. I can hear all the noise out there, and I can see it picking up on the thing. Give me 1 sec. I didn't realize how sensitive the speaker is in this, but yeah. And even using some of the egg crate that you would find, we found downrange, any type of anything that's going to get somebody off of the ground, provide some protection from the heat loss that's going to happen just through conduction, and then for their skincare is going to be the best thing to do.
Okay.
So so I think we kind of talked about the different types of way you're gonna lose heat, and I think really there's some things that we do that people don't realize that you're actively cooling your patient, and these are some things I think are you can try to prevent, or at least know that's what you're doing. And one of those is I see some guys carrying around iGel LMAs, which is great. It's a great rescue device. It's a great, like, if somebody's obtundant and they'll accept an LMA just to get the tongue out of the way, it provides a conduit to provide positive pressure ventilation. It also provides the ability to just ventilate and not have an obstruction. But in a cold environment, that LMA is going to be whatever the temperature of the ambient temp is. So let's say it's 50 degrees outside or 60 degrees or whatever it is. That LMA is going to be 60 degrees. And you slide that LMA in, and if you just typically look at where an LMA sits and then you look at your carotid arteries, like, the LMA runs right parallel with your carotid arteries. So by putting a cold LMA in somebody, you're actively cooling them. So I always tell, like, if your plan is to use that LMA, try to keep it somewhere on your body or in your backpack that's close to your body. So at least it's warmer when you put it in somebody. So that way, and obviously, like, the immediate issue is the airway. So if it's cold, it's cold. You're going to do it. But just know that LMA, so the way the iGel works is the body heats the LMA, and then it kind of expands a little bit to create the seal. So you already know that you have to use your body heat to make this thing work appropriately. So the colder it is, the more body heat you're going to lose just through conduction by warming that LMA. And then just through regular respiration, when you are tidal volume ventilating, your nasal passages and your oropharynx and everything else, like, that tidal volume when it hits your lungs is 98.6 degrees. And if you bypass all those structures that typically warm your that tidal volume, every breath you're cooling the patient, right? So every breath that goes in, your every heartbeat, your whole entire cardiac output goes through your lungs. So you're actively cooling your patient. So you'll see in ICUs, they always typically will humidify and warm the ventilatory gas that goes through the patient. We typically don't do that in the OR. We'll use like an HME filter, which is a heat moisture exchanger. So that's like if you do have a ventilator, you do have a circuit, you have an LMA, you have anything, like, it is pretty small. So as far as Cuban weight, I would use it. And then they do have HME filters that are also viral and bacterial filters. So that way you can protect your circuit and your ventilator from bacteria and any type of viruses. So you can reuse the same circuit as long as you put that HME bacterial viral filter in the most distal portion of your circuit. So, yeah. And that's typically what I'll carry. I don't want to carry like 10 circuits. I just carry 10 of those filters instead.
Right. So obviously, like, the HME was designed to go on to like an ET tube or a crike is what it was designed for. Not every patient has been criked or intubated. Could I use that same kind of device, say on like a face mask? As long as you can get a good seal, then they're breathing out of that.
I don't know. I guess I really never thought about that. I know there was, one of the medics that I got to know, he was trying to come up with a device to heat the oxygen that was coming through at the very distal port. So like you put like a simple face mask on, and he figured out a way to heat that at the very distal portion of the oxygen tubing, how to heat the oxygen that came out, so the tidal volume would be heated. And I don't know if an HME filter, I think that would probably be pretty uncomfortable for the patient, the type of seal you would need. And then also those filters do create resistance to ventilating, right? So that's the other issue. But yeah, I don't know. I mean, once again, it's just one of those things. I don't think there's a wrong answer or a right answer. I think you just try it, see, you can try it on yourself, see how uncomfortable it is to try to ventilate through it, and then, go from there. But yeah, you're also decreasing the amount of moisture you're losing through the respiratory tract as well at that point. So if you don't have a lot of fluids to rehydrate your patients, I mean, I think you're losing like 600-700 cc's. My physiology teacher would be pretty upset with me if I'm saying this wrong, but you lose this like 300 to 400 to 500-600 cc's of fluid just through evaporation in your ventilatory tract every time you exhale.
Yeah, I know. Just maintenance fluids is roughly for an adult, roughly 125 an hour. So yeah, you got to be getting rid of it roughly at that
somehow.
rate.
Yeah. Yeah. So some of the other things that I've found with specifically downrange with trauma patients, even in the summer, in some of the super warm places that we've deployed to, if somebody's out running around in a gunfight or it's really hot outside, you're just sweating. Everything is wet, right? Like all of it's wet. So, and your body's trying to cool itself through evaporation, right? So that's one of the ways that we cool our own bodies. And now that patient becomes injured and they're no longer moving, they're soaking wet just from their own sweat, and that continues to evaporate. So that the socks, the pants, everything is wet. You got to get that wet clothing off of them eventually, right? Obviously, point of injury, like you're probably gonna cut the clothing off anyway. But for the most part, if you're just grabbing somebody and moving them out, the quicker you can get that clothing off of them and something dry on top of them, the better. So that way, and then even if you can dry them off, so that way you're not continually losing heat through evaporation. So, and then if you put somebody that's like wet in a HPMK or some sort of heating element that some of the more austere things, like you're still going to lose body heat because your body is just simply trying to evaporate all that fluid that's on them, whether it's blood, whether it's vomit, puke, like whatever it is, like you're going to lose heat through that. So if you can keep them dry, or at least scoop out some of the wetness that's in those HPMKs or whatever device that you have, the better.
Yeah. Yeah, absolutely.
Sorry, go ahead.
So I was going to say, one of the other things I see that we're doing to our patients to get them cold is like just blood resuscitation. And, just following the CPG, if they need blood, they say you can send the first unit cold. Okay, so that's coming out of the refrigerator. We're about like 3 or 4 degrees Celsius. And, let's say they're running around, so maybe it's warmed up a few degrees, but that's pretty cold. Like, and I see guys kind of deliberate, like, well, if I give him this cold blood, he's going to get cold. But if I don't give him the blood, he might die. How do I deliberate this? I
think that's the classic kind of board question. It's like you got 2 bad options. Well, which is the option that's the least bad? Or you've got the risk of giving the blood is making a patient more hypothermic, but then the risk of not giving the blood is they're more acidotic and they don't have hemoglobin to carry oxygen. So I think one of the medics I worked with, he had a great way of kind of thinking through those problems. He's like, what's killing the patient first? Right. So I was like, that really always stuck with me. It kind of prioritizes like how you would do things. So what's killing the patient first isn't the hypothermia per se. It's the hypovolemia. So send it, right? Like you got to get them, you got to get the organs perfused. You got to get the hypothalamus perfused, which is the portion of the brain that controls heat. So if your hypothalamus is hypoperfused, like you're not going to have shivering, you're not going to have all the normal responses that you would have to hypothermia. So give the blood, knowing that you're going to make the patient cooler, at least. Just some of the things I read just to talk through this is that 1 unit of packed RBCs taken right out of the refrigerator at 2 to 4 to 6 degrees Celsius is going to drop the patient by 0.25 degrees Celsius. So, which some people might go, oh, that's not a big deal. You start at 37, you go down to 36.5. Most of these guys are probably starting at 35 or 34 degrees. So 0.25 degrees is quite a bit. And then knowing how to get back that 0.25 degrees and what it takes, even in a normal operating room, doing this in a deployed environment is going to be a lot more challenging. So, but I think, I mean, the CPG is correct. They need the blood. If you can't heat that first unit of blood, they still need it. It's two bad options. The worst option is to not give the blood.
Yeah, I definitely agree. Like I can work with a patient who at least has a heartbeat. I can always start to gain ground. If he's dead and warm, it doesn't matter.
Right. Hypothermia is an alive person problem if you can keep them alive, right? So you can fix hypothermia. You can't fix someone who's deceased, right? So I think that's a pretty straightforward risk benefit.
Yeah. No, I definitely agree. So I guess a little more maybe on the practical side. You know, you've been to the deployed environments. You've received patients in less than your standard OR type conditions. You know, let's say you receive your average trauma patient. Maybe they've started receiving blood. Maybe they haven't. Maybe they have their ready heats on and their HPMKs, and they're kind of brought to you. Like, if you wouldn't mind, just kind of walk through the different things you've done to get a patient warm in kind of that rural or austere environment.
Yeah, so I think the number one thing, this is a team event. The one thing, and I think you've seen it, I've seen it, where the amount of times that the patients are left uncovered is truly, if you can decrease that by 50%, where people just keep reaching in, looking, and then leaving it open, and then somebody's like, oh, we forgot to close the whatever device, typically it's an HPMK. So if you can really, everybody on the team, be good stewards about exposing the patient when they only need to be exposed, and only exposing the areas that need to be exposed. That's typically probably the best way to keep a patient warm. And then I always carried some sort of not a baseball cap, but a skull cap or something extra for a patient to immediately put it on them. I usually chose like a wool skull cap. That way, if it got wet, it still provided warmth, and I would almost immediately put that on if it wasn't already on. And then, depending upon the environment that we're in, if there was a way to heat whatever we were in, it was make sure that it's warm. Now, I think the biggest problem with any active rewarming is it requires a lot of energy. So if you're using batteries to use keep your blood warmers, like we all know this, like batteries don't last that long. You maybe get a liter or two of blood through whatever device you have that heats the blood. If you're in a building and there is a way to heat that room, I would say try to heat it in which way you can. One of the other things that I would do is and once again, for the most part, I'm not trying to do this out of a backpack on, super duper far forward. And if we are doing that, then obviously you have to go much lighter. But if not, we always had, for the most part, a mattress pad that specifically went with our litters, and we always made sure we had it. So that way that we're solving two problems with that. The mattress pad will prevent skin breakdown, which obviously leads to the sequelae of wound infections. And then also it prevents the heat loss through convection from underneath the litter, or through conduction if we had to put them on the ground.
Was that just a regular air mattress camping one, or did you get a nice thick one?
It was a thick one, I believe. It specifically fits on like the Black Hawk litters, and we would use those. Just simply, it was pretty robust and it was pretty thick. And then the other thing we would do is we would always, anytime we heard that we were getting a patient, we would break open our own HPMK, break open our own ready heats, put the ready heats, obviously get them heated, put them in the HPMK. So that way, if the HPMK or however they were brought to us, if it was saturated, wet, what the Navy, right? Like a lot of water. So, so that way we could get them out of whatever wet stuff they're in and get them into something dry. So those are typically the ways that we would do this. And then if we had some sort of a structure, whether it was a tent or any way to kind of seclude the environment that we were in from the outside environment. Those are typically the things that we would do. Yeah, I mean, and once again, we didn't have bear huggers. We didn't have, because it's just, those require a generator. Like, you're not doing that out of a battery. Like, and if you do have, some of the commercial products out there, like a Goal Zero or something like that, I don't think the Goal Zero is going to be able to keep up with like a bear hugger. I think it keeps up with your fluid warmers, but nothing that's producing that much heat.
Yeah. Yeah. Like I've tried, just like hot air dryers. Mm-hmm. And building like a little wind tunnel underneath the litter, so it'll kind of trap the heat and push it up. But trying to connect it to any kind of battery backup or anything like that, like it just is not working.
Yeah, I know that I had spoken to some of the helicopter-centric folks, and they were trying to figure out a way to take some of the forced heat that comes out of some of the helicopters and create a device that you could kind of an adapter that you could hook on to one of those and then run it through a hose and then put it on a bear hugger. I think the dangers with that is the bear huggers, the temperature is regulated. Like, it's 40 degrees or 42 degrees or whatever it is when it's over the patient, where I'm not sure they were able to figure out a way to, because I think that heat comes out of there. Usually if I'm on a helicopter and there's a heater, like I'm up against it trying to like get my plates warm and just to keep warm, and it gets really hot. So I think that would potentially cause burns to patients. So if you could use the own heating elements of whatever you're in, whether it's an LMTV or a Humvee or whatever, but I would say just know that if that heat is super hot, it could potentially cause some first, second degree burns.
Yeah. Even that ready heat will, if you put it on the skin, I've definitely seen that burn people.
Yeah, and I know I've tried where I had my mattress pad, and then I had a ready heat, and then I had a wool blanket. And I would put like an HPMK directly on top of that. And that seemed to, and this is just me trying to lay on it, see what it was like. And it definitely felt like it was warmer than if I was just laying on just the mattress.
Yeah. Oh, yeah, definitely.
But then again, like or the ready heaters, they're a lot of weight, right? Like if you're carrying like 15 of those things, it's like 20 pounds of ready heats. So that means 20 pounds of stuff that you can't carry.
That's very true. Very true. And they have their own limitations, even though it's like chemical reaction, but you go up in altitude or like if it's really cold out, like they don't work that well.
No. And then the other, for us, the only way that, and I don't even know if you would call it actively rewarming the patient, but it's using fluid warmers. There's some ones that are out there that are good, some that are out there that maybe the flow rates are a little bit slower. But I noticed that you're really it's under normal physiology in an operating room using a fluid warmer, keeping the ambient temperature warm, using a bear hugger. Even then, it takes hours to warm a patient. So now go into, an environment where you're not in an operating room. You can't increase the ambient temperature. You only have ready heaters and you're using a fluid warmer. Like, it's going to take some time to heat that, rewarm that patient. And eventually you're going to get to a point where if you've got the bleeding controlled and you've resuscitated them enough, like you're no longer putting warm fluid into them, whether it's blood. And I would assume you probably don't have the batteries to warm your maintenance fluid. You might probably going to have to save your batteries for another injured patient that comes in if you have to start doing a massive resuscitation. So it's challenging. I think really the best thing to do is prevent them from getting any colder, and then trying to do things to eventually get them warm again would be your best bet. And that's, whether it's in making sure that you've got some sort of something under them, whether it's a foam, egg crate, a sleeping pad, blankets. Even if you put them in their own sleeping bag, like try to put something. I've slept on the ground in my sleeping bag. It's freezing. It's cold. It's uncomfortable. It sucks, right? So if you could get something under them, whether it's, using leaves or pine straw, like I've used pine straw. Pine straw works pretty well. Like anything you can to insulate them from the ground. I think that's a good way to prevent the conduction heat loss. And then obviously just keeping them covered as much as you can prevents the radiation heat loss and prevents the convection heat loss. And then also using your HME filter and keeping them dry to prevent the heat loss through evaporation. So doing all those preventative measures, and then I believe like your ready heats can then do their job. If you're preventing all these other avenues through heat loss, then you can at least try to rewarm them with your HPMK. But I don't think the HPMK will keep up if you're not doing all those other things. So, and then the downstream effects, obviously the hypothermia is part of the lethal triad. This like significant platelet dysfunction. You're never going to get them to stop bleeding. And then the other downstream effect is, and I believe if you drop a patient off in PACU and they're 35 degrees or below, the increased incidence of wound infection is like 30%, which is huge. That's my fault, right? If I don't get somebody warm enough, and I'm not, yelling at the OR nurse to increase the room temperature and getting a fluid warmer, and using some sort of underbody warmer if I predict that this is going to be a case where they get cold, and then using an upper body and a lower body bear hugger to keep them warm. That's kind of on me, right? So, and then I know we spoke about other ways, like if somebody's really cold, to actively rewarm them. So, and I've seen this a couple of times, not in the deployed environment, more when I was in Minnesota, where you'd put two chest tubes in on the left side, and one of those chest tubes you're infusing warm water, and one of those chest tubes is the egress for that warm water. So you're kind of warming the left side of the chest, where the left side is closer to where the left ventricle is. We would put OGs or NGs down, and we would actively, just put warm fluid in their stomach, and then I don't know if I've ever seen this. I think, we definitely talked about it, where they would do like a diagnostic peritoneal lavage, but it wasn't for diagnostic purposes. It was just to lavage the mesentery and other vascular structures and warm the body. And that was more like cold water drownings, or people that were, just for whatever reason, out in the cold, and they would come in and they were significantly like very cold. So we would have to try to actively rewarm them. And I've seen it done a couple of times, but I think now you can use ECMO to warm patients. I think that's one of the avenues that they would do. And then that you're taking blood out of them, putting it through a machine, warming it, and putting it back in them. You can rewarm somebody really fast. And then some of the other things I've seen is like some sort of central line or a PA catheter, where they can warm that PA catheter, so that way you're warming the blood that way. But that all requires a significant amount of energy and effort and expertise, etc. None of which I mean, I could probably put some chest tubes in. I don't know if I would dork around doing a DPL. I'd probably goof it up. I could obviously put an OG or an NG in, but I need warm fluid to do that. And in order to get that warm fluid, you need to heat the fluid somehow, which requires energy.
Yep.
So
no, I've also heard of like the Foley, like take the fluid out of the Foley, warm that fluid, so it's outside of the patient's body. You warm it up via whatever mechanism you have, and then they pick it up. The fluid runs into the back into the patient's bladder. They let that sit for 5-10 minutes and then drain it back out.
Yeah, I would. I mean, that's definitely something you could do for sure. I mean, the urine should be sterile. If you don't have sterile water to be putting inside a Foley, like if you can heat up the urine that's in the bag and then put it back in. Yeah. I mean, I would, yeah, all the above. I'm not gonna be like, what did you do? I'd be like, oh, wow, that's a great idea. Good job. So yeah, I think it's a very challenging, problem set in a deployed environment, even when it's warm out. When I say warm, I'm talking, 120 degrees, in the summer, and we still get patients that are 35, 34 degrees that are hypovolemic trauma patients. It's so just, decrease the temperature by, 30, 40 degrees and then make it wet outside. And then it becomes even more of a problem. So I think understanding how heat loss occurs, trying to prevent those types of heat loss, trying to prevent the radiation, trying to prevent the evaporation, trying to prevent the convection and conduction, then the stuff that we have, the mechanisms that we do have to rewarm a patient in an austere environment work that much better. But if you're not preventing radiation and convection, you're leaving the patient uncovered for 2 minutes, and you're like, oh, I got to cover the patient. I don't think those interventions work very well, and it's not because they're not effective. It's because we're not being effective by preventing all the other ways of heat loss. That kind of makes sense. So. And it's just not on people's minds a lot. They're not thinking about it. But I think about it because it's my job to think about it. And I always try to make everyone else on the team think about it as well. And if that requires me to I don't care if you're hot, it's not about me or you. It's about the guy on the table. So that's who it's about. This operating room is not for me. It's not for my comfort. It's for they're here. We're here for them, not to make it nice and cool for us.
Right.
So,
understood. Is there anything else that we missed?
I don't think so. I think the only thing that we didn't talk about is where to take temperatures. Right?
Okay.
So,
yes.
That's the other hard part. Where do you get an accurate temperature? PA catheter obviously is pretty accurate unless you're doing some sort of cardiothoracic surgery where you're doing off circuit or on circuit bypass or actively cooling the patient. Esophageal temp probe usually works pretty good, but if you put that esophageal temp probe right next to an LMA that's 30 degrees, that's probably going to be inaccurate. They talked about the tympanic membrane is pretty good, but it's very user specific. You really have to do a good job in doing it. And then there's the skin temperature, which can be definitely not your core temperature. There's the Foley thermistors that you can use, but once again, you need a Foley that has that capability. So really the one that we use quite a bit in the OR is either esophageal temp probe, or sometimes we'll take that, we can put it in the nasopharynx. That usually gives us a pretty good idea of what the temperature of the brain is. And then also there's the rectal temp probes that you can use, but obviously an awake patient's not going to appreciate that. But oral temperature, but that can be challenging to do in somebody who's obtunded or intubated. So, but yeah, I think like whatever your plan is, like just know like it's downsides of whether or not it's going to be accurate for you.
Right. Well, luckily they only give us the CVS thermometers.
I call them the mood rings. I was just like, oh yeah, yeah. I mean, and we have them too. Like it's not that I've not used them, but I think the provider, at least what I've read about them, like if you put them on the forehead, the provider variation in reading them can be pretty real. And then sometimes you put it on them and it's not even registering and you're like, oh, I don't believe that thing. And I was like, no, the patient really is like 32 degrees. Like you're like, no way, you just peel it off and like try to figure out a different way. But if that's your thing, if that's what you got, that's what you got. But I would also like believe it. Like if it doesn't even register, they're probably that cold. Right. I think that's the problem with that the mood ring that I call it. Sometimes people just don't believe it. And then it's like, no, they're cold. They're really cold.
So this kind of just brought to mind. So, I have some of those, those colorimetric type stickers. Mm-hmm. I was thinking put one centrally, maybe near the carotid notch or something. Mm-hmm. But then take an actual temperature, like a rectal or oral temperature, and just see where that is and see how that compares. And then kind of judge, is he warming just based off of that? Because I'm really just looking for it to go up. I'm not. Yeah, right.
Like, yeah, I think. It's a swag. So as long as the swag is going in the right direction, you're probably at least you're doing okay. I think the colorimetric devices require the skin to be perfused. So if you have somebody that's truly hypovolemic and they're really not perfusing well to their skin, it's probably going to be not as accurate as something that's a little bit more invasive. But once again, like you're just using it, like you put it on there and it says 33 degrees and in an hour it says 34 degrees. Sweet. Like good enough. Like you're going in the right direction. Or in the same sentence, like if you see it go down to 32 degrees, you're like, ooh, well, this is not good. Like you're just looking for the trends. So that's typically, for me, when I use those, I'm looking for a trend. I just want to see it trending up.
Okay. Do those esophageal temperature probes, do they connect to like the Tempest or...
They should. I'm not as familiar whether or not. I'm sure they should connect to the Tempest. Like the temp probes all have, whether you're using an esophageal temp probe, skin temp probe, or any other type of temp probe, they all have the same connector for the cable that uses the on the monitors. So they're pretty universal. Like all the temperature cables are pretty much the same. So as long as you have the right hookup, the male to female end, you should be fine. And the other thing, some of the esophageal probes, you can actually hook an earpiece up to them, and you can actually listen to the heartbeat. So if you don't have all your fancy monitors, you can at least listen to whether your heart's speeding up, slowing down. And you can also sometimes listen to lung sounds that way as well. So you can hear a bronchospasm pretty quickly, or you can hear. Usually we'll use them on like pediatric patients, not necessarily, or not esophageal. We'll just put a pericardial stethoscope on, and I've actually heard like fluid kind of coming into the lungs. I know that, but that just takes hundreds of cases where you're just listening the whole case and you're like, that doesn't sound right. And you're like, you realize that they probably just had a little bit of blood go into the airway.
Okay.
So,
well, very good. Is there anything else we missed out on?
No. And I always try to listen to the podcast afterwards, but if people have questions, let me know. I could try to shoot you some answers and go from there.
Nice. Well, thank you, Kevin. I appreciate it.
All right, Dennis, you have a good rest of your day, and I'm sure we'll talk again.
that's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.